Good morning, everyone. Today, we will be diving into the fascinating subject of Wallenberg syndrome. This condition, also known as lateral medullary syndrome or posterior inferior cerebellar artery (PICA) syndrome, is a neurological disorder that affects the brainstem. It is essential for us as future neurologists to develop a comprehensive understanding of the pathophysiology, clinical manifestations, and management of this syndrome. Let us begin by discussing the basics of Wallenberg syndrome. It was first described by German neurologist Adolf Wallenberg in 1895 and is caused by a vascular lesion in the lateral medulla. This region comprises vital structures, including the spinal nucleus and tract of the trigeminal nerve, the nucleus ambiguus, vestibular nuclei, and the descending sympathetic tract. The most common cause of Wallenberg syndrome is a disruption in the blood supply to this area, typically due to occlusion or infarction of the vertebral-basilar artery system. To understand the underlying mechanisms of Wallenberg syndrome, we must grasp the anatomy of the brainstem and its intricate vascular supply. The brainstem consists of the midbrain, pons, and medulla oblongata. It plays a crucial role in controlling vital functions like breathing, heart rate, and consciousness. The brainstem receives its blood supply mainly from the vertebral-basilar arterial system, which encompasses the vertebral arteries, basilar artery, and posterior cerebral arteries. In this section, we will delve into the intricacies of the vertebral-basilar artery system. The vertebral arteries arise from the subclavian arteries and fuse to form the basilar artery, which supplies blood to the brainstem, cerebellum, and posterior cerebral arteries. These arteries have an essential role in maintaining proper blood circulation and oxygenation in the posterior circulation territory. Wallenberg syndrome is a neurological condition that occurs when there is a blockage or injury of the posterior inferior cerebellar artery, PICA. The pica is an important branch of the vertebral artery, which supplies blood to the lateral medulla, a region of the brainstem. When the pica is blocked, it results in decreased blood flow to this area, leading to the development of Wallenberg syndrome. Wallenberg syndrome is characterized by a range of symptoms, including facial weakness, difficulty swallowing, and impaired coordination. These symptoms arise due to the involvement of key structures in the lateral medulla that regulate these functions. Therefore, understanding the anatomy and function of the pica is crucial for diagnosing and effectively managing Wallenberg syndrome. By studying the pica and its distribution, medical professionals can identify the location and extent of the blockage or injury, leading to a more accurate diagnosis. This knowledge also helps in developing appropriate treatment plans and rehabilitation strategies for patients with Wallenberg syndrome. Now, let us explore the relationship between medullary lesions and Wallenberg syndrome. The medulla oblongata contains various nuclei responsible for sensory and motor functions. Any disruption in blood supply to this area can lead to ischemia and subsequent dysfunction, resulting in the clinical manifestation of Wallenberg syndrome. The specific location and extent of the lesion play a crucial role in determining the severity of symptoms. In this section, we will discuss the sensory disturbances experienced by patients with Wallenberg syndrome. The syndrome typically presents with ipsilateral loss of pain and temperature sensation in the face, contralateral loss in the body, and ipsilateral Horner syndrome, which includes ptosis, meiosis, and anhidrosis. The involvement of the spinal nucleus and tract of the trigeminal nerve accounts for the sensory deficits observed in this condition. In Wallenberg syndrome, motor dysfunction plays a prominent role. This condition commonly results in weakness on the same side of the body as the lesion, affecting both the limb and the palate. This is due to involvement of the pyramid, which controls limb movements, and the nucleus ambiguus, responsible for palate function. The resulting motor impairments can greatly hinder a patient's ability to carry out daily tasks. To achieve the best outcomes in rehabilitation, it is crucial to implement comprehensive management approaches targeting these motor deficits. In Wallenberg syndrome, the dysfunction of the vestibular nuclei results in vertigo, which is a spinning sensation, as well as nystagmus, an involuntary eye movement. These symptoms can lead to difficulties with balance and coordination. Moreover, the involvement of the oculomotor system can lead to double vision, diplopia, difficulty moving the eyes to look in certain directions, gaze palsy, and additional nystagmus. These vestibular and oculomotor manifestations play a crucial role in diagnosing and understanding Wallenberg syndrome. Wallenberg syndrome is a neurological condition that often presents with dysphagia, or difficulty swallowing. This occurs due to a disruption in the nucleus ambiguus, a region of the brainstem responsible for coordinating the muscles involved in swallowing. As a result, patients with Wallenberg syndrome are at an increased risk of aspirating, or inhaling food or liquids into their lungs. Early recognition and proper management of swallowing disorders are essential to minimize the potential complications associated with dysphagia in these individuals. In individuals with Wallenberg syndrome, There is frequently dysregulation of the autonomic system as a result of the impairment of the descending sympathetic tract. This can present as abnormal fluctuations in blood pressure, heart rate, and patterns of sweating. It is crucial to carefully monitor and address these autonomic disturbances to ensure the patient's overall health and improve their quality of life. In this section, we will explore the differential diagnosis of Wallenberg syndrome. Given the overlapping clinical manifestations, it is essential to differentiate it from other conditions, such as lateral medullary infarction, lateral medullary hemorrhage, and brainstem neoplasms. Understanding the distinctive features and relevant diagnostic techniques will aid in accurate diagnosis and appropriate management. Finally, let us discuss the prognosis and rehabilitation strategies for patients with Wallenberg syndrome. The prognosis varies depending on the extent of the lesion and the severity of symptoms. Rehabilitation aims to optimize functional independence and includes interventions such as physical therapy, speech therapy, and occupational therapy. A multidisciplinary approach is crucial in providing comprehensive care and improving outcomes. In conclusion, Wallenberg syndrome is a fascinating neurological condition that highlights the intricate connections between brainstem anatomy and clinical manifestations. Through a detailed understanding of its pathophysiology, clinical features, and management strategies, we as budding neurologists can contribute to improving the quality of life for patients affected by this syndrome. Thank you for your attention, and I look forward to further exploring this topic with you.